so no relevant conflicts. I guess what I want to say is you could sort of sit back and relax. You've had sort of a stream of things that you have to learn and memorize. I don't know if any of this has made it to the boards yet. Hopefully it is. But I think a lot of this is sort of a step back, sort of the Chinese proverb, teach a person to fish and they'll eat for a day, or to teach a person, give a person a fish and they'll eat for a day, teach a person how to fish and they'll eat for a lifetime. I think actually even the fishing in that analogy, we're talking about putting in safety nets for diagnosis, and to think about how we're going to memorize all these syndromes and pass them on to questions on the boards is sort of less of what we're about, but more to sort of give you an appreciation. First of all, another reason to relax is you're in good company when you're making diagnostic errors, which you're going to be doing inevitably. We're going to show you some data on that. And so, number one, diagnostic errors are important and frequent and missed appreciation. There's a growing interest in this. So again, as I said, I don't know whether this new National Academy of Medicine report is something they expect you to be aware of and quiz you on the boards, but it's something that really is important development in medicine. Traditional approach is limited, which I would include memorization and relying on human memory. These are ways of unreliable ways to ensure that diagnostic errors are not made or cause harm. Many of them are low leverage, some of them are counterproductive. Health information technology, and again, usually when I talk, this is sort of the main subject of discussion, how the EMRs are causing us to make more diagnostic errors, copy and paste, not listening to the patient, having to stare at the computer, not even seeing the rash that we should be making for the drug that they're taking. But HIT has a role in both causing as well as preventing these errors. This whole business about metrics and you're going to be measured on your diagnostic errors, we're trying to push back on this and really talk about how a different way of approaching culture, including working with the patient and learning from each other and sharing errors. It does not mean more and more tests so you don't miss everything, so doing head-to-toe MRIs for every patient who has any kind of complaint in the emergency room. And we're going to need to be working with patients to make this work effectively. A lot of this is grounded in actually my funding has been from the malpractice insurers. We teach a course around medical malpractice and best practices. And you'll see some of that data here, but the idea is not to scare people about malpractice, but really to help people learn lessons from those cases. This is a study that was done in Massachusetts. About a quarter of patients have experienced a medical error. And the interesting thing, because this is very little of where we were putting our effort in patient safety, the majority, the leading one was diagnostic errors. You can see that's leads surgery, bad outcomes, or wrong treatment, or medication errors, missing a side effect of a drug, et cetera, wrong patient getting a drug if they're allergic to penicillin. This is a study that's brand new, just came out really a few months ago, that was done nationally, Institute for Healthcare Improvement. Roughly, again, similar number, 21% experienced a medical error, and there it is again, misdiagnosis leading the pack here. So you're in good company here, as I say, when you're making errors. This is, you can see that some of the factors that go into this and some of the ways we're going to prevent it, we're going to talk about in a second. This is just some data that we collected, again, showing the diagnostic errors for malpractice cases by a factor of really 7 to 1 over medication. What kind of diagnoses are being missed? You can see here that it's really cancer in terms of primary care, then heart disease and infection, et cetera. As you move further down the list, again, the cancers we're talking about that consistently lead the list year after year, malpractice insurer after malpractice insurer, colorectal, lung, prostate, and breast. So a lot of this is not esoteric things about these diagnoses, but simple systems and pitfalls that we're going to mention in a second. This was another aspect of this study, and basically it said that when these cases do arrive, they're twice as likely to be settled or to lose in trial. These are things that are less defensible than other types of errors. And again, this was just literally a few weeks ago. This is the latest data from Coverys. This is another malpractice insurer. The previous was from the Harvard Crico malpractice insurer. Again, diagnosis, leading cause of claims. These are the areas, history and physical, and ordering of tests, etc. And I'm going to sort of focus on actually a slide that you don't have here, but so when they looked at their claims, they had what they call clinical judgment as sort of a leading factor. What did clinical judgment mean in terms of the cases that they've reviewed? We're talking about hundreds of cases nationally. They had something they call narrow diagnostic focus, inadequate or inappropriate testing, misinterpretation of a diagnostic study. If somebody sees a result and misinterprets it or misses something on an x-ray, failure to adequately assess the patient's condition, failure to obtain a specialty consultation. And again, this is, I didn't have my new slide here, do I? Okay, all right, no problem. We went to great lengths to do that. So here you have an error that we'll skip that for now. This is culminated in a report that hopefully at least people have heard of and are aware of, and again maybe be mentioned as something that the boards want you to know. But they had 8 goals, and I think again each of these, as you step back, we can think about hopefully productively how we might incorporate this into each of the kind of diagnostic situations and scenarios and types of patients. The first they talk about is having more effective teamwork. So this is really involving the patients more. It's not the doctor working alone making a diagnosis, but there's a whole team involved. We'll touch on some of the details of that. The next one is professional education and training, and actually that's one of the slides I was going to talk about, but doctors need to be taught, clinicians, things such as heuristics and biases, availability bias. This is when you've seen a recent patient of a certain diagnosis. So we just saw angioedema in one patient, so the next person that comes with a very minor, trivial thing, you're going to sort of work them up for angioedema or hereditary edema. You're just vivid in your mind, or somebody has a headache, you missed a brain tumor, so you're going to work up every patient. Representative bias, where you think that somebody sort of resembles a certain characteristic without taking into account the base rate of the particular problem. Ensuring that health information technologies support patients, and we're going to spend the most time on that in a second. Develop and employ approaches to learn from these errors. So this has just got to become part of the way we practice, where we share cases and we share mistakes. It's not a matter of us hiding or being embarrassed or afraid. There's lessons that we need to learn from each of these times when we miss a diagnosis or delay a diagnosis, and we need to be doing this with each other and even with our patients. We need a work system that supports this culture, including having enough time to see the patient. I mean, I know when I have 5 minutes to see a patient in the office versus 20 minutes, I'm going to be making lots of errors in terms of not eliciting history, key history, not giving the patient a chance to talk about what they're concerned about, not explaining a good follow-up plan. A reporting environment and medical liability system that sort of takes the gun away from our head and allows us to do the kinds of things I'm mentioning in terms of culture and learning from errors. A payment system that, in short, supports enough time to see the patient and doesn't disincentivize us to do the right thing, the wrong thing. And of course, as a researcher, who could not want more funding for this, but really the funding for this kind of work has really been very minimal. They have a whole set of figures about what the diagnostic process is. I'm a pretty simple-minded person, and for me, it boils down to these 3 circles on this Venn diagram. So on one hand, you have diagnostic process failure, something that goes wrong in the diagnostic process. Somebody, the sodium comes back 122 or it was 144, they're in the hospital, and it turns out they switched the specimen between the patient in bed 1 and bed 2 in a room. So that doesn't necessarily lead to labeling somebody hyponatremia or working them up. You repeat the test or an adverse outcome. But consider Linda McDougall. and I'm using her name, not violating any confidentiality. She was on the cover of Newsweek. So she woke up from her breast surgery, radical mastectomy, bilateral radical mastectomy, and the surgeon said, "You don't have breast cancer." And she said, "I'm so glad, doctor, you got it all out." And he says, "No, you never had breast cancer. We switched the specimen with another patient, and we misdiagnosed your breast lesion as cancer when it wasn't." So she obviously had a diagnostic process failure that was, similarly to that sodium being switched, but obviously led to a misdiagnosis and an adverse outcome in her case. And so obviously we're most worried and concerned and want to focus where those three circles, those three Venn diagrams intersect. And by the way, one of the things that lower left blue circle, we're missing and delayed diagnoses all the time. Maybe we diagnose somebody as having a bacterial infection, URI, and it's a viral, or vice versa. We didn't really do anything wrong. We did the appropriate exam or testing. Sometimes we can't tell that, but it doesn't look like we did anything wrong. There's no adverse outcomes. So we're working in these three zones, but hopefully trying to minimize, especially the process failures that are sort of the near misses that we can think of in our practice, where we miss a test result and then we find it, it's of no harm when we follow it up, but other times it can be consequential. I put Marshall Wolf here. I'm sure he probably has spoken at this course historically. He's sort of the great diagnostician in Boston. I think if you want to have a good diagnosis, people would say go to Marshall Wolf or somebody like him, or so the kind of people you're hearing standing at this podium. And of course then there's Gregory House or Sherlock Holmes, these great thinkers. But it turns out, I think the quote that resonates most powerfully and I think importantly for moving forward is from Don Berwick. People are probably familiar with him. He's from Institute for Healthcare Improvement. He headed Medicare and Medicaid. He says, "Genius diagnosticians make great stories, but they don't make great healthcare. The idea is to make accuracy reliable, not heroic." And I saw this quote in 2002, and it kind of changed my life. I mean, it just sort of opened my eyes to sort of thinking about, as an internist, I prescribe drugs and I make diagnosis, and this is sort of a way of sort of thinking about how we can really make a diagnosis accuracy a system property and hard weave it in. And there's two concepts, at least the way I think about it, and this is where this fishnet, safety net comes in. One is to sort of be aware of where things can go wrong, and the other is how to put in safety nets that would prevent this. And so I think this sort of, the diagnostic risk safety net is a sort of a specialized type of this, what's called situational awareness. In high reliability organizations, we talk about this all the time, where people worry. These are people on nuclear submarines that worry about all the things that could go wrong. This guy Sullenberger, who landed the plane in the Hudson, they had rehearsed what to do with a water landing, with that very takeoff. There'd never been a water landing of a domestic air flight in the United States, but they were worrying about anticipating what could possibly go wrong and how to prevent this, and putting in safety nets that in that case was very life-saving. Appreciating the limitations of diagnostic tests and uncertainty. Again, lots to be said about this, but every test really has its sensitivity and specificity. People really need to know what the pitfalls and how you order it, how you interpret it, and I don't think we're very good at that. And we shouldn't have to do that in our head, by the way. You shouldn't just have to sit there and memorize. We should be prompted by this. There's ways of helping us. Making failures visible, so if somebody's test result wasn't followed up, it's not that it's just buried until the next next clinic visit, but in fact, is obvious. If there's like a red flag that it's on my results queue that I have to extinguish before then. So, and again, I just put one quote here, and then we'll just give you a couple of practical kind of ideas. Perhaps the most distinguishing feature of high reliability organizations is their collective preoccupation with the possibility of failure. I guess people are preoccupied with the possibility of failing on the boards here, so maybe it's sort of a different way of thinking about this. But they expect to make errors, they train their workforce to recognize and recover them, They continually rehearse familiar scenarios of failure and strive hard to imagine new ones. Instead of isolating failures, they generalize them. Instead of making local repairs, they look for system reforms. So one of the things we want to sort of get people oriented is to think about what is a diagnostic pitfall. And we've gone through malpractice cases, and we've come up with sort of some generic concepts here. So disease A is mistaken for disease B, following right from the talk you just heard. So bipolar is mistaken for garden variety depression, right? Failure to appreciate the limitations of a test. A woman comes with a breast lump, and you confirm it on physical exam. You send her for a mammogram, and it's normal, and you say you have nothing to worry about. Your mammogram was normal. And of course, I think we now know that that's not adequate. If there is a palpable breast lump, even though we use mammography for screening for breast cancer, that's not a diagnostic test to rule it out. Atypical presentation. Presuming a chronic disease accounts for new symptoms. So somebody's having a swelling of their knee, so they have rheumatoid arthritis, so it must be that rather than not thinking about infection or gout. Overlooking drug or environmental causes. I think, again, last several talks help us think about the importance of that. Pancreatitis or carbon monoxide. Failure to monitor evolving symptoms. So if somebody's getting worse over time, we're not following up on them. So these were the things we found, for example, in breast cancer cases. And again, just to reemphasize the fact that false negative physical exam or screening versus diagnostic mammogram order. So if I just order that mammogram and they say it's normal, they don't realize it's based for symptom, false negative ultrasounds, etc. So it really sort of boils down to sort of a model that hopefully, again, you can put into focus a lot of what you've had over these last few days here. So on one hand, you have red flag symptoms. And we need to think critically about the science of them, the sensitivity, specificity, how often they're going to be there to help us. Don't miss diagnoses, right? So certainly spinal epidural abscess is not a diagnosis we want to miss, even though back pain is very common. And we don't want to work up everybody with back pain for spinal epidural abscess or malignant metastatic cord compression. And then diagnostic pitfalls. What are the common things that people are doing wrong? The traps, the holes that we're falling into individually and collectively, and how can we learn from them? We're actually trying to get this diagnostic pitfalls into Harrison's textbook of medicine. We hope to have that in the next edition. So it'll have pathophysiology and signs and symptoms, and what are the pitfalls to avoid for each of these diagnoses. That at least we're going to do it for selected chapters. And again, the idea is not to have you memorize these, but to have it there when you need it, when you're looking up a certain diagnosis. And again, the idea of safety nets is thinking about how can we use HIT to hardwire this. Again, we've published a paper here. I won't walk you through it. A couple things. One was in New England Journal, where we've really gone through how these tools can help us more reliably gather information. How can it aid in a differential diagnosis? So I don't have to remember it and memorize these lists, but they should be there to help me. And hopefully the computers should be smart enough to know some things about the patients and their history and their labs to help me prioritize them. Things to help us do Bayesian calculations. So sensitivity, specificity, predictive value, we do terrible in our head. You're going to probably be asked to do that on a board question. And, I guess you can take out your calculator or some count on your finger and stick diagrams of 1,000 patients present, but there ought to be aids to help us, electronic aids where the computer can really be helping us. Referral for specialists or even real-time consults. Look at this rash in this history. Dr. Dermatologist, what do you think? Should I be worried about angioedema? Is this something serious? Is this urgent? Is this nothing? So these are the kinds of things we're trying to think about, how to get the computers out of the way and out of the business of really distracting us and perpetuating wrong information with copy and paste, and how to use them in a very powerful way to overcome, help us visually display information and keep us from forgetting things, etc. So I mentioned clinical documentation as one example of this, and I think people kind of know, this idea. It's sort of the paperwork you do after the job is done, if you're caring for the patient. But we'd like to think the CYA could stand for a canvas for your assessment, where you're really going to paint a picture for yourself the next time you see the patient. What were you thinking, or the next person that is going to open the chart or see the patient? So things such as you're having a differential diagnosis. Most of the malpractice cases that are related to diagnostic errors, there was no differential diagnosis. Yeah, they said the chest pain was, costochondritis. They never even listed a differential diagnosis. It could be pulmonary embolism. And what the likelihood to weigh this, to think out loud. Doesn't mean I'm right, but at least I'm saying that, and the next person that can come along say, you dummy, this is obviously not this and more likely that, but we should have, again, a culture where I should be game for exposing myself and learning and getting that feedback. And by the way, the patients also need this, because they're reading these notes. We now know 23 million patients have open notes, and that number's growing. What's the etiology? So what's the underlying cause? How urgent is? And really, in some ways, this is the most important. How certain am I? So let me write in the note this. I'm really not sure about this. It seems like this is probably a benign cause for the headache, but there's certain things I just not making me uncomfortable. I'm just not sure to write that in the note, to be able to explain that to the patient and obviously create different follow-up. Unfortunately, our follow-up systems are lacking. They're what we call open loop systems. So here's an example of an open loop system where the sprinkler goes on every day, whether it's raining or whether the lawn is flooded. This is what diagnosis is right now. So we make these diagnoses, we don't get systematic feedback. I guess if we're lucky, the patient will come back and say, I'm not better. But you could also get a knock on the door from the subpoena from the malpractice case saying, guess what you just missed? That person had a subdural, or you are dissecting aneurysm, that you were dismissed. So how do we do this? How do we create closed-loop systems, which in engineering is a fundamental principle of what we need? A key is really follow-up and feedback. We've done some studies where we're calling patients by automated systems, or nurses call patients just to see how they're doing. And it turns out a lot of patients who are not improved we're not hearing about. 16% of the patients were not getting improved, but only a third of them really had contacted the clinician. So we see feedback and follow-up as a key factor in patient safety. It allows us to deploy the test of time, watchful waiting, because it's safer to do that, have a differential diagnosis. Emphasizes that diseases are dynamic. I don't know how many of the lectures you had here talk about it's not just signs and symptoms at one point in time. Symptoms evolve, and we need ways of operationalizing that. So, this is not easy, of course. First of all, it takes time. There's discontinuities. Patients go from one doctor to another, and especially if they're not happy with the diagnosis. How much of this feedback are we going to have? Are we going to keep alerting doctors? What's the signal to noise? Do we get enough messages in your inbox already? This is really the last slide here. We're going to have to involve the patient in all this. And again, I don't know how you ask this on a board type question, but we're going to have to be working collaboratively with our patients, what I call, or people refer to as co-producing diagnosis. It's not like we make a diagnosis, the patient's the consumer, I'm the producer. No, diagnosis is co-produced by the clinician and the patient. And so first of all, they have to give us a good history. They have to share their hunches, even if they seem crazy to us. They read something on the internet, because we need to know what they're thinking, what they're worrying about. Following up, when I asked them to get some blood tests, I was just this morning contacting a patient waiting for this test results that I asked her to go take because I was worried about her. She never took them. So we have to work together to do this. So what will it take at the provider and the institutional level to make these roles flourish? So again, this is just a little graphic poster. Nothing about us without us is for us. So just to summarize and hopefully get us back on time, because we're good here with our 30 minutes and get you out of here. Which of the following are examples of situational awareness constructs that hold potential for helping clinicians and patients anticipate, recognize, or prevent diagnostic error? So A, red flag symptoms. B is context-relevant, don't miss diagnoses. And 3 is what I call just-in-time reminders about potential pitfalls. What do people think? Or D, all the above? Yeah, all the above. And maybe this is too obvious. Similarly with this, so that's D, all the above. Which of the following regarding diagnostic errors would you say is not true? Patients reveal that 1 in 5 have experienced a medical error, the majority of which are diagnostic errors. B, the best way to decrease diagnostic errors is to order more tests to screen for all possible diagnoses. C, improving patient follow-up by phone to check how symptoms are evolving is an example of enhanced follow-up and feedback. And then better clinical documentation goes beyond just CYA, but includes improving recording of differential diagnosis, your degree of certainty, and the follow-up contingencies, what to watch for. And again, hopefully, again, this isn't too obvious, but this idea about, well, I don't really know what's wrong, and let's just order 1 million tests, and that's how we're going to be better diagnosticians. Really, first of all, the insurance companies are not going to let us continue to do that, nor patients who have a high co-pays for each one of these tests. But also, it really doesn't help us with our thinking and our appropriately taking care of patients. So again, here's the answer. B, it's not a good idea. Unselected tests without proven screening value in low probability situations, highly vulnerable to false positive errors. We'll get all sorts of incidentalomas. We won't know what to do. We'll be harming people more than we're helping them. Better to focus on the patient and their history and the more likely diagnosis and being conservative.